Good evening, my dear friends and colleagues all over the world, and welcome to a new episode from the Egyptian Vitreoretinal Society around the retina world in 30 days. Each day, we are hosting a distinguished guest and a star in the field of retina and vitreoretinal surgery. And today's guest is really a special one. Special on both the personal and professional level. On the personal level, I consider him a very dear friend. And on the professional level, he is an icon and a star in the field of ocular oncology. Today's guest is Professor Aaron Singh, Director of Ocular Oncology Service at Coles Eye Institute at Cleveland Eye Clinic in the USA. Dr. Aaron Singh is a well-known name in the field of ocular oncology, and he has so many publications, and he is around 160 publications, as I read in the biography. And as well, he is the editor of the British Journal of Ophthalmology, and he has edited one of the major books in ocular oncology, Clinical Ophthalmic Oncology. Welcome, Dr. Aaron Singh, to our program.
That's a very generous introduction. Thank you so much.
Thank you, Aaron. And to start with, Aaron Singh had a long journey. He is originally from India, and he was in the UK and then in USA. We would like to know how this journey started and how it ended in the USA.
Well, it's a long one, so I'll kind of highlight the main components.
Yes.
So I was actually born on a ship. So that's kind of where my journey starts, very unusual. And my parents were traveling to London at the time. So this is many years ago. And I was born somewhere in the waters south of Malta on the
Okay.
ship. I tracked the journey of the ship. And after that, of course, we reached London, and that's where I was registered. So from birth, I become a British citizen, but my parents never really lived there. They went to Russia. My father worked in the diplomatic services. Russia is a bad name now, but those days, not so bad, I don't think. But in
Yes.
any case, so my first 4 years of life were in Russia, and then we moved back to India. So I grew up in India, studied there, and
Yes.
then when I finished my medical school, I wanted to learn more, and so that took me to England. And then from England, I thought maybe that's where I was exposed to ocular oncology in St. Bart's Hospital under Mr. John Hungerford, very nice man, and he encouraged me to pursue this field. So that was in 1989.
Okay, that's a
I've been
long.
in this business of ocular oncology for 33 years. That's a long time. And then from there, I came to US to study in Philadelphia under Dr. Jerry Shields. And from there, I just stayed back. And after that, I've been in the US for many, many years. And for about 20 years now, I moved to Cleveland and we started our own service. So it's a long journey, but it's also very rewarding, very fruitful, and also very fulfilling. So anyone who wants to get into any business, just have a long-term view of it. Don't expect anything to happen tomorrow, but if you continue at it, I think 15 years later you will see something. So that's kind of my general thought
It's
about it.
quite an interesting journey. I mean, you were born in the Mediterranean, and this explains me some of the Mediterranean spirit you have.
Well, anyway,
Really friendly
yeah.
spirit. Yes. And well, did you ever dream to be a doctor? I mean, the family, your father
Yeah.
was a diplomat,
Yes,
so
sir.
you
No,
didn't
I'm
go
so
into.
okay. We have four brothers, and my all four of us are all doctors. We are all professors. I'm the youngest one.
Okay.
Different fields. I'm the only ophthalmologist, but we are all full professors in our own field. My brother, older one, radiologist, and the one above is pediatrician, and the one above is internal medicine. And so I'm the youngest one. So this wasn't a surprise that I also kind of followed the path of my older brothers, and so I became an ophthalmologist in the process.
And why did you move from the UK to USA?
Again, mostly for the fellowship training. I came as a fellow, as a clinical fellow. Again, in 1989, I realized I wanted to be an oncologist. And those days, it wasn't such an exciting field because all we could do was some radiation and some enucleation. There wasn't any real chemotherapy for retinoblastoma, for example. Plaque therapy was, of course, there. And so it was limited in terms of what you could do, but I just felt very comfortable taking care of these complex patients with huge emotional and personal needs. So that kind of drew me into it. And I came to US mostly to study because I read the book on ocular oncology by Dr. Jerry Shields. So I said, well, let me go and learn from him. So I worked under him as a fellow for 2 years. Yeah.
Okay. And how long did you stay at Wills Eye Hospital in
So after
Philadelphia?
that, Jerry was very kind enough and invited me to stay back as faculty, and I stayed there for about 3 years. And after
Okay.
that, I realized that to grow on my own, I needed to be at a different place, and so Cleveland Clinic had an opportunity for me, and I was very happy to move.
You really established a great oncology service there, and it's well reputed all over the world.
Thank you.
And now, a little bit away from business and medicine, what are the places you would advise us to visit, whether in India, in the UK, or USA, since you
Well,
are multinational?
yeah, I like history and tradition, and I think that's where we all feel grounded. We all are what we are. Our faces, our names tells us who we are. So that's not easy to eradicate. That's what you are. So I believe that there's a reason for it, and this our culture or heritage enriches us and gives us kind of a down-to-earth feel, which we should always maintain. And so I like places that are very rich in that aspect. So I would say that Egypt was the one place I really, really enjoyed with my family. We went around everywhere. So that's because, again, it's steeped in history and culture and layers of it. Of course, just like India, so that you can imagine, we are kind of interesting. We have many kinds of people that we talk to, and we have no issues. And then the other places that I really liked in the same aspect were Japan and South Korea.
Mhm.
They're modern, westernized, developed, yet they have their whole tradition and culture that's remarkable. So there is a way you can achieve that. And I thought, to me personally, those two countries and Egypt. And I also say that I really also enjoyed visiting Israel because I
Yes.
found again similarities of many cultures, many histories, and one over the other, literally, physically. You dig and you find another something. And so that was amazing. In a
Yes.
small land, there is so much happening. So that to me was also an interesting place that I
So
visited.
you're fascinated with history and culture,
Correct.
as most
Mhm.
of us do. Yes. So what are the hobbies of Aaron Singh?
Aaron Singh has no hobbies. Aaron Singh, Aaron Singh just sits and writes and thinks. That's what I do. I enjoy music. I listen to it. I don't. I travel. I've been to about 40 countries, and my aim is to go another 40 or so once the COVID business settles down and I start to moving around some more. Yeah, so I really enjoy travel a lot. I enjoy listening to music, and then I just sit and write. That's my.
Well, I mean, since you enjoy traveling, we will be looking forward to you having you in Egypt again once
Oh,
we have the opening of the Grand Egyptian Museum, which is going to be next year probably.
very good.
So
Thank you.
thank you. And any favorite food,
Well, I
meal?
like kebabs.
Kebabs. Then you have to come to Egypt.
Yeah. So, you name the country where there's good kebab, I've been there. Okay. I've been to Iran, looking for kebabs. Okay.
Yes. In Turkey, they have good
Turkey.
kebab as well.
Yeah.
Yes,
That's
yes.
that's the richness of food, and the food is not just something that we eat; it's something that we share with friends and family. So it brings certain memories and customs and traditions. Like certain festivals, you eat certain foods, and certain celebrations, you do certain things. So food is just more than just the thing that you're eating, but it's also steeped in so many layers of it, if you want to call it that. Yeah.
I totally agree. I totally agree. So, what are the dreams for the future for Aaron Singh?
So this is personal. So I just turned 60 this year.
Oh,
And I think that I'm going to be professionally active for another 10 years. So, in the last 10 years of my professional life, I feel that I need to become a mentor to many people as I can. And not just be busy building my own self and own something, but to share it and to mentor other people. So in the last 10 years of my professional life, my aim is going to be
Teaching.
more and more of a mentorship, not just teaching, but helping people how to navigate through this complex business of medicine, and how to establish their own oncology services and things of that nature.
Well,
Yeah.
that's really a noble dream, and I have to admit you are a great mentor and teacher for many people, and your lectures are well attended. This is no compliment, but this is a fact.
Thank you.
So now we have finished this personal part to know Aaron Singh closely. We're going to a short break, and then we come back with a very interesting presentation from Aaron. Now for a break, and we will come back soon.
Well, thank you so much again for inviting me in this exciting journey. Uh, the topic I chose is iris tumors and when to worry. I know this is a vitreoretinal society, and iris isn't the part of retina or vitreous, but this is also an intraocular component, and these tumors are not necessarily very well understood or recognized. So I hope many of you will benefit from some of the experience that I'm going to share with you. I'm Arun Singh from Cleveland Clinic. So iris tumors particularly have unique challenges because they are very common. Certainly benign ones are very common. These tumors are generally very small when identified, and they can be of large variety. And the patient typically has no symptoms and they have normal acuity. So you're starting with a patient who has no issues, and you suddenly look at the iris and say, oh, you have a tumor, and we need to do this and we need to do that. And that makes it a little difficult for a patient to accept what you're saying because he has no symptoms and his vision is normal. So the way we think about all of it is to examine the patient, take a history, and you come to like one initial kind of working diagnosis. You got to have some diagnosis to wrap your head around with. This may not be a final diagnosis, but you need to have some initial diagnosis that anchors your processes and thoughts. And then you say, okay, I'm not sure about it, but there may be one or two differential diagnoses or alternative diagnoses. I think if after an examination of a patient you cannot narrow down to three possibilities, then you must not be in this business. You really have to learn this much, or understand or read or whatever you need to do to be able to come to one or two or three diagnoses after finishing the initial examination. So we say one initial diagnosis and two differential diagnoses. What can you do in terms of imaging for iris tumors? You can do only one of three things. You can either do an anterior segment OCT, you can do fluorescein, or you can do UVM. And there isn't any fourth thing you can do. And then you say, well, what can I do to manage these patients? You can do only four things to the patient. You can either observe them if you think it's benign, or you may think of biopsying the tumor because it looks malignant to you or you're suspicious in some way. And there are several ways of biopsy techniques, and you can radiate the patient. So there isn't a whole lot that you can do. And I'm going to introduce this new technique of excision of iris tumors, and that's one of the reasons I wanted to share that with you. So let's talk about what kind of or spectrum of iris tumors. We have iris cysts, that's very common. We talk about melanocytic tumors, nevus or melanoma, metastasis, and other non-melanocytic tumors such as vascular tumors and others. And don't forget, inflammations and infections and granulomas are more common in real life than tumors or malignant tumors for that matter. So this is the kind of various groups of entities that you will come across when you're going through iris tumors. So let's say here's a patient on examination. You see a triangular pigmented mass with nodular appearance. These are seeds on angle. On gonioscopic examination, you can see seeds in the angle. So to me, this isn't a nevus. This is highly suspicious for melanoma. So seeding is one important finding when you start to think that this iris tumor could be something more serious. Here's the patient you're examining. You see a little bit dark iris here. You see a small nevus here, perhaps another nevus here. But the issue with this particular pigmented lesion is that you're not able to see the margins completely. So you can see the upper part, the lower part, the nasal part, but you can't see the ciliary component, whether that's involved or not. So it's very important, therefore, to be able to see all margins of the tumor with imaging if you have to. So here you do gonic examination and you can see, oh yeah, the iris is actually displaced centrally. So therefore, you know there is a ciliary body tumor that's pushing the iris centrally. So this isn't an iris nevus. It's in the ciliary body. Okay? And you do the transillumination of the different patient, you can sometimes see the area of involvement here. But UBM is what's going to tell you. So OCT is what people do all the time, but OCT is not good for the ciliary body region. It's good for the iris. So if I want to study in this, like in this particular case, ciliary body, you really need to do a UBM, which was done in this case, and one can find the tumor is extending into the ciliary body. Well, how do you know? Well, you look at the ciliary body here, and you go ciliary body on the other side, and you look at the size, and you'll know it's thicker. That's the way you know. How do you know it's not normal? Well, you have eroded some of the processes here, and it's nodular and solid and surrounded, and it's thicker than the other side. So to me, ciliary body extension makes it more suspicious. Can we have iris and ciliary body nevi? Yes, and I'll show you an example of it later on. So what next? So you say this patient has an iridociliary mass that's pigmented, and because of ciliary body extension, we're concerning that this could be melanoma. You can excise it, but a simpler way would be just do a needle biopsy from this area here, take the sample, confirm it's melanoma, and can do a radiation plaque, for example. You were not going to enucleate an eye like this. This is a 20/20 eye, and would be so even in the future, except the patient would get a cataract from radiation, and you can deal with that a year or two later. So that's that. Here's another patient with the same thing. You can see angle involvement, ciliary body here, and the iris is pushed more centrally. You say, oh, this looks like a ciliary body mass, ciliary body melanoma, and because it was extending into ciliary body, that's one component of a serious tumor, something that's worrisome, and we need to act upon it. And this was excised, iridocyclectomy, and on histopathology was a ciliary body nevus. So we talk about iris nevus, we talk about choroidal nevus, but we never talk about ciliary body nevus. It's just that we can't see them. Or if we see them, we don't know what we're looking at because we don't know how to diagnose them. So this is one example. We had 3-4 of them. You can't really tell them apart. I don't think we can clearly say that this is a nevus on a ciliary body tumor. So you end up excising or biopsy. So this is a case of ciliary body nevus. So ciliary body nevus do exist. Always keep that in mind. And here's a young child. He was 15, I think, when I saw him. Maybe 17 at this point. You say, oh yeah, this is an iris nevus. It's a small brown tumor in a Caucasian and a white person with a light green eye. And the tumor is stromal. You can see it's almost like spherical, up and behind and sitting on the lens. So you say, oh yeah, come back, we'll just follow you 6 months, 3 months, 1 year, whatever. Initially, newly detected lesions, we would like to follow them initially 3 months and then make it 6 months if stable and make it longer as we go. No one would say that this is an iris melanoma unless I showed you a picture from 5 years ago, which is right here. And he had come to me at that time also. This is from my own clinic, my own office. I said there's a growth here. And not only just a growth, the tumor has become more confluent, it's solid, and you can see it's all filled up, the spaces are filled up. I excised this tumor. This young boy was 17 years old and was melanoma on pathology. So how will you have a growth documented? Well, if you don't take a picture of a nevus, you'll never know if it's growing or not. So really, I would say that the minimum you want to do when you see a patient with iris nevus or pigmented tumor, please take a photograph of it. Even no matter how small, no matter how insignificant, just take a picture. It doesn't matter. Slit lamp photos are available everywhere. and this was melanoma. And this is after excision and pupilloplasty. He's done well. Here's a patient with a vascular tumor. Now, this is not a nevus, everybody would agree with that. And this could also be, say, an inflammatory granuloma. Patient has neovascular glaucoma. You're not able to see iris neovascularization, but this is a kind of amelanotic tumor with vessels in it. Patient gave a remote history of renal carcinoma. This was a metastasis from renal carcinoma. And this was confirmed with transcorneal biopsy, which showed it to be metastasis renal cancer, clear cells of the kidney cancer. After that, this patient, what did we do? Elderly patient, we put a plaque and give Avastin in the anterior chamber for neovascular glaucoma. The tumor shrank within 4 weeks. So one procedure, one treatment, you're done. These are all palliative therapies, right? You're not able to alter the patient's survival by doing all of this, but certainly you're stopping the eye from getting painful and coming to enucleation down the line. That's what you did. So here's the patient with a kind of, well, I would say dark brown mass. It's not arising in the iris necessarily, but kind of sitting anteriorly to it and has a clear component here. So this could be like a hemorrhage inside some kind of a clear cyst on the surface of the iris. And we did a fluorescein angiogram to see what it was. It was just totally silent. There's nothing connecting into it. It's dark. No vascular connection whatsoever to the iris. So we say we don't know what it is, but it's really not in the stroma of the iris. And if you did the UBM and you follow the solid part inside with the small arrows and like an outer lining with black with the larger arrows, and if you can follow the iris stroma to the base of it, you get an impression that this is sitting on the stroma. This is not actually in the stroma. You can actually imagine the interface right here. And I just told you that neva and melanoma are stromal tumors, spherical, right? This isn't any of that. It's sitting on the top of it. So anyhow, we excised this, just shaved it at this interface. If you can imagine putting a blade through right here and excising it, and that's what we did. So we didn't know what it was, and that was the reason to, this is after surgery. So we did not cut the sphincter, did not cut the stroma of the iris, just shaved it at that interface. Beautiful dissection, same patient, by the way. You can see the iris nevus is still here, okay? And pathology shows iris varix, rare kind of a vascular anomaly of the iris. So you say, oh, this is melanoma, I'm going to cut it. Not really, you don't have to cut. And I just said UBM, you can see that interface. And that just made me think that I can just dissect it right at that level. Okay. And here's a young man who went for contact lens checkup, and you can see again, a melanotic mass here is also vascularized, has no symptoms. He goes every year for, he's 24 years old, he goes every year for a checkup, and on the contact lens examination, they find this. Recent onset is another feature with, you think, hey, something, how can this be a nevus? It just suddenly popped up in a 24-year-old. It's vascular. You can see that it's vessels, a little pigment here. I did not biopsy this because this is vascular, and I thought if I put a needle into it, he'll get a hypema. Again, asymptomatic patient, 2020, right? Normal pressure. You put things, they get hypema, then you're dealing with all the issues with it. So we excised it, and actually was a melanoma. This is totally amelanotic melanoma of the iris. That's what we suspected because there was no inflammation, it was quiet, but it was vascular, and I thought this has to be that. I can't imagine it's anything else. Clear margins, okay? You see clear margins on both sides. Here's a patient with a vascular tumor, just like the other one. I said, I know what it is. It's melanoma. Not really. It has very fine vessels. It's sitting on the iris, again stromal. You can see on fluorescein. And this is actually very interesting. This was leiomyoma. So leiomyoma is a rare smooth muscle tumor. This is arising from the smooth muscles of the blood vessels of the iris. It's not arising from the muscles on the back layer of the iris. It's arising from the muscles of the blood vessel. Therefore, it's a vascular tumor. It was excised. So I don't think we can look at these kind of tumors and figure out what it is. We can suspect that, yeah, there's something serious here, we need to take it out because it's vascular. So vascularity is one thing that you need to worry about. Here's an African-American patient with kind of an irregular whitish mass. It's eroding through the iris. So we know it's coming from ciliary body, right? And you can see it's kind of invading into the sclera. Here's the sclera, and you can see the extension is kind of getting into the scleral channels. So like, what is it? I have no idea. He didn't have any other history that could give you a clue. Obviously, he's African American, so you don't think of melanoma. One could have done a needle biopsy, I get it. But we excised it, and this was actually sarcoidosis. So this is sarcoid granuloma. So I know everybody's seen sarcoidosis, but this is one kind of sarcoid nodule. Okay? Biopsy proven, so you can't argue with it, right? And anyway, then we sent him off to the inflammatory people. So here's a patient with a large tumor. So this is not a nevus for sure, right? So we know it's melanoma, and he was plagued with after FNAB. I tend to do more and more biopsies because although things are very clear in this particular case, before you do radiation, before you do enucleation, I think it's important you try to get a sample, because that way everybody knows why we're doing what we're doing. So this is a spindle cell pigmented and this atypical nucleus. This is melanoma, and he had a plaque put on. Okay, I'm going to give you some warning signs. Okay, recent onset, etc. So we'll come back to that. So here's a quick case of a 59-year-old man, recently detected tumor on the examination, partially pigmented, partially amelanotic, is vascular on fluorescein angiogram. That made me think I should do something about it, and I excised it. It was stromal tumor. And the old way would have been to kind of do a incision in the limbus, almost 1/4 or 1/3, and then kind of go from there, like the old style extracapsular kind of approach here. But we decided to do it differently, using what's called laparoscopic kind of approach with multiple small incisions. So we say make an incision here, go down, cut the iris. You can imagine just working from the opposite end, all inside the AAC with the viscoelastic, and then removing the tumor in a tubing. So here's a little, I don't know if we have, the first part is not showing in the video, but anyhow. So these are the incisions made with the 23 gauge scissors from MST nowadays that we use. And then afterwards, the tumor is floating freely in the anterior chamber, so phakic eye. Then we take this DMEC cannula that has been loaded with viscoelastic, and you just insert it through the wound, and you aspirate the tumor into it. And the reason is you do not want to contaminate the wound with the tumor cells. So this is the guarded hydroaspiration. You're hydroaspirating the tumor. And afterwards, you do the pupilloplasty. You can preserve the tumor architecture. You just express it onto the filter paper without touching it. Iris is very fragile tissue. So nobody touched the tumor directly, cut around it, aspirated it in a lubricant, put it onto the filter paper and send it for the pathology so they can see the margins. And then do the pupilloplasty afterwards, post-op 1 week. So the advantage is that these patients don't get astigmatism, they have rapid recovery because there are multiple small incisions. So we can all understand why the patient would heal better. And this patient was actually iris melanoma, a mixed cell type. So here's a sample, very beautifully preserved and no folding of any kind, and the margins were negative. So here's another patient we did that for him. So phakic eye, same approach. You can see the stitches are on the opposite side of the tumor. Not here, normal would be here, but this was just on the other side. And here's another, as a young lady with a pigmented tumor, and this is what was done. And this, she's after pupilloplasty. You can't even see the iris defect. The pupil seems to be in good size, equal on both sides, because the first suture goes to the collarette. So we published that the first paper some years ago, and now we have over 50, 60 cases of this technique. So coming back to iris tumors, we're trying to differentiate particularly nevus from melanoma And that's not an easy path. That's no clear difference. We can say this is clearly nevus, this is clearly melanoma, but few things that help you. Recent onset, like a case that we showed you. Growth, for sure, I think is important. Size, anything bigger than 3 millimeters in any dimension is important. Any kind of vascularity, hyphema from the tumor is important sign. And if it's ciliary body extension and kind of seeding. If you see any of these things, don't call it a nevus, okay? Do something about it. So if you don't know what to do, send to somebody who knows about it. I would say just that would be the best way to go. And so, and the last one, of course, when you don't know what you're looking at, may be other reason to think about doing something like the man with an iris varix. So with that, I stop. Thank you so much for inviting me to participate. And these are some of the working tips in dealing with patients with iris tumors.
Thank you very much, dear Aaron, for this very interesting presentation about actually a condition that may present a diagnostic dilemma in many cases. I will pose some few questions for you just to highlight some points. When do you do fine needle aspiration biopsy versus excision biopsy? And what is the rate of positive yield in fine needle aspiration biopsy?
Okay. Both are very important questions and clinically relevant. So first of all, needle biopsies. If we think the tumor is melanoma, then I would do a biopsy. If I think the tumor is malignant, I would do a biopsy, needle biopsy first, because I may have to do radiation therapy, I may have to enucleate this eye, I may have ring melanoma, different things. So I would do a fine needle aspiration biopsy. In our center, overall negativity rate is about 5%. So I tell the patient that 95% of the time we will have a diagnosis. We will have the cells, we will have the diagnosis. Now, let me give some more clarification here. We are using liquid-based cytology. That means we aspirate the tumor cells and we put into a liquid called Cytolite, and we'll kind of flush the needle back and forth 3-4 times, and then it's taken to the lab, they spin it down onto a slide and they look at it. Of course, you need to communicate with the pathologist, what are you looking for, that's number one. And number two, that these samples are not very cellular, they'll have only a few clusters of cells, and they have the pathologist, cytopathologist has to know what to look for. You say, I'm looking for, I think it's melanocytoma. So they know they're looking for, big cells with a lot of pigmented and can't see the nucleus. And they'll see that and they say, yes, thank you, it's melanocytoma. So you have to prime them as to what they're looking for. So in cytology, and it can be difficult, sometimes they will say the appearance is borderline, favors nevus. The appearance is borderline, favors melanoma, or clearly melanoma, or clearly nevus. So if it's a patient that I suspect has a nevus, I would not biopsy it. It's driven from your clinical judgment. If I suspect that this tumor is melanoma, I will biopsy it. And coming back to the second part of the question, when would you do iridocyclectomy? I would do iridocyclectomy if the tumor is not a melanoma. I see a tumor, I can't tell what actually it is. And it's circumscribed enough that I will try to excise it. Because if it's melanoma, radiation is very effective in ciliary body. It's very easy to do technically. You put a plaque on it, they have very little mobility, so you don't have to cut out a melanoma from the ciliary body. That's really not needed. All you need to do is establish a diagnosis. So it's driven by the clinical judgment as to what is your working diagnosis.
Another question, Aaron. What gauge of needle are you using for fine needle aspiration biopsy?
Yeah, we are using 25 gauge needle. For anterior segment, we're using short size needle, 25 gauge. And we bend the needle at the hub so it's not straight in, but at a certain angle. Yeah, it's 25 gauge short needle.
And then you aspirate within the lesion.
Yes, and people have used shorter gauge, smaller needles like 27 and 30. It's clearly shown that the gauge of the needle matters, because thinner the needle, less will be the cells that you're going to get. But we do 25 and it seems to work out very well. We have done hundreds of cases over the years.
Yes.
We haven't had any problems with it, no.
Another issue that we are facing sometimes is that when you do a pluck for an iridociliary tumor, you get an intense uveitis postoperative. How do you control that?
So this is due to tumor necrosis and pigment shedding. So the tumor undergoes fragmentation, necrosis, inflammation. So steroids, we will give topical steroids. The tumors that we see are not heavily pigmented. Of course, in your part of the world, people have brown irises and more pigment, so this will be more common. Just topical steroids. It could be many weeks before it settles, but it will settle.
It will settle at the end. Well, I think Aaron made us a very nice presentation and a very informative one about iris tumors, how to deal with them. And now I would like to conclude this episode. I would like to thank Aaron for his contribution, and we are looking forward for him to visit Egypt again, maybe next year when this COVID business is over. And tomorrow, expect us with a new guest and a new episode in a different country and with the EGVRS Retina tour around the world in 30 days. Thank you very much and good evening and have a nice evening, everyone.
Thank you,
Bye-bye.
Hani. Thank you.
Thank you.